Welcome, everyone. I'm Nanette Elster, and I'm a faculty member at the Neiswanger Institute for Bioethics at Loyola University Stritch School of Medicine in Chicago. And I want to thank you to the first Loyola event in this new speaker series that's organized by the National Collaborative on Humanities and Ethics in Dentistry. I'm going to be your moderator for today, so if you have questions, please post them in the Q&A. Before we get started, I wanted to give you a little background on this new series and go over a few housekeeping items. The National Collaborative on Humanities and Ethics in Dentistry is currently a partnership between four universities. It's the Neiswanger Institute at Loyola University, the CU Center for Bioethics and Humanities at the University of Colorado Medical Campus, the McGovern Center for Ethics and Humanities at the McGovern Medical School from the University of Texas, Houston Health Sciences Campus, and the Department of Health Humanities and Bioethics, the University of Rochester Medical Center, and the Eastman Institute for Oral Health, both at the University of Rochester School of Medicine and Dentistry. So this series aims to create unique and valuable opportunities for reflection, learning, and teaching on ethical issues in dentistry, and to stimulate progress nationwide in using arts and humanities to improve dental practice, research, policy, and education. This program is being recorded and will be sent to those who've RSVP'd, as well as posted to the CU Center for Bioethics and Humanities website. And as I mentioned, if you have questions, please put them in the Q&A. We'll try to get to as many as we can and leave time for that. But with all that housekeeping, I'm really so pleased to introduce to you today's speaker, Carlos Smith. Carlos is going to be discussing spirituality, religion, and oral health. He serves as the inaugural Associate Dean for Inclusive Excellence, Ethics, and Community Engagement at the Virginia Commonwealth University School of Dentistry. He's a general dentist, an ethicist, an ordained clergy. He's an associate professor of dental public health and policy and currently serves as president of the American Society for Dental Ethics. And he's an active fellow of the American College of Dentists. There's a lot more I could tell you about him. He's amazing, but you're going to get that from his presentation today. So I'm really, really pleased to introduce you all to Carlos Smith.
Well, good morning, afternoon, evening, maybe, depending on where you are, time zone wise. It's a pleasure to be with the National Collaborative on Humanities and Ethics in Dentistry to really engage a topic that is a bit sparse in the literature. But also kind of broad, right, in terms of scope. So I think that's fun, but also maybe challenging. So I want to put that up front, like whatever your really looking forward to being discussed. I might not touch on because it's such a broad topic, but I think we'll have some fun and do some great engagement and learning together. So we are going to just go ahead and get started here. Um, I don't really have any disclosures to speak of. This is really just highlighting what was on the flyer around learning objectives, but I want to go ahead and get started from this place, right? I am a associate professor here at Virginia Commonwealth University, which is located in Richmond, Virginia. I hope all of you have some semblance of engagement or awareness around both land and labor acknowledgments, right? Particularly when we think about ethical practice, ethical duty, ethical sensibilities. I think the cynical side of me is often kind of like, oh, these are cute, but like, what do they mean? Are they helpful? We're not necessarily giving land back to indigenous communities. How are we thinking about a reparative or restorative ethic for both indigenous and descendants of the formerly enslaved? But I still think it's a really important practice to bring to the surface and acknowledge. And so this is just really the VCU land acknowledgement. I have added around labor because I think that that is important to acknowledge. And really, when we think about healthcare and when we think about the topics for today around spirituality and religion, I really want us to begin to get our minds kind of turning around these notions, really right here in the center, these notions of erasure, violence, and oppression and the general sensibility that we as humanity, all of us, right, from almost antiquity up to now, have almost this odd compulsion with hierarchy, right, and rank and order. And file, if you will. And so just let that sort of ruminate in the back of your mind as we move forward with this conversation. I certainly want to position myself, and I think when I share this on LinkedIn, I don't usually go this personal when I give continuing education conversations, but I also don't usually have an opportunity to engage the very theological side of my brain, right? So positionality wise, for this conversation about spirituality, religion, and oral health, I thought it necessary to offer a little piece of myself to ground us, right? So if you look at the far left of my slide, and this might be jarring for some, but is the reality from which I come. This is actually a appraisal of an estate that includes my three times great grandfather, who I'm amazingly blessed to know his name even on my paternal side, Harrison Ensminger, who was formerly enslaved, and in 1855 in South Carolina, at 18 years of age, he was appraised for $900, right? So I'm gonna go somewhere with this arc and this journey and this story, but certainly for many African Americans in the United States, particularly I would say for me as someone who has identities as sort of oddly, proudly Southern, if you will, as complex as that is. My paternal line is from South Carolina, many generations over, and my maternal line is from both Alabama and Georgia, many generations over. So as we then move forward to the next picture, you see this wooden framed church that is in what is called Haleburg, Alabama, which is my maternal sort of line, birthplace, if you will. And this is my family church that is actually on our family land that my family still owns and has owned since the late 1800s. It is still an active, functioning Baptist church. It is actually the oldest still functioning Black Baptist church in Alabama that was started by formerly enslaved folks around 1870, 1871. It sits on Stovall Drive, which is my grandmother's maiden name, Stovall. And then as you transition across the slide a little bit more, I would be completely remiss to do any work around spirituality and religion without lifting the essence of my grandmother, who actually passed away just recently on election day, 4 days shy of her 106th birthday. For that, I am extremely honored, grateful, and proud. But she was an ordained minister, and in many ways, defied lots of norms around gender, around place, around race, time. And if you can see that very top photo, in her late 60s, early 70s, she went back to school. She didn't have the opportunity to pursue formal secondary education after high school, but went back as a much older adult and got her associate's degree in religion. And so then if you transfer down to this very bottom photo, that is actually me and my youngest daughter, who's now 3. So this was probably about 2 years ago or a year and a half ago on FaceTime to show what she looked like in her more present stage. And then just a little bit about me, positionality wise, my story. I am from Columbia, South Carolina. So this weirdness or ironic narrative of South Carolina certainly being the first state to secede from the Union, and now I am located in Richmond, Virginia. I can actually look out my office window at the Capitol of the Confederacy, the White House of the Confederacy, is right outside our dental school. I went to dental school at the University of Michigan School of Dentistry. I went to undergrad at Hampton University before that. And then after dental school, I pursued theological education, went to Duke Divinity School and received my MDiv. Um, Practiced for many years. I still practice. I have on scrubs today because Tuesday is actually my practice day in our faculty practice, but transitioned to academics about 10 years ago. And that's why I have ADIA there, which is our umbrella of dental education. And then I do represent the American Society for Dental Ethics. So I know that was a lot to throw at you, but I think it's important to ground, particularly a conversation around spirituality and religion from whence I come and from whence I've been birthed, fashioned, shaped, honed, if you will. Okay. So there are kind of three domains of thought that I want us to really think about the ways in which spirituality and religion can have an effect on oral health generally, the delivery of oral health care, and also the ways in which the oral health care workforce functions, right? So those three domains for me are really the patient and society at large, the oral healthcare team, and then both the individual professional, but also the profession as a whole. So as I talk today, as we engage, as you may have questions, I think locating the content within these various domains is my goal. So what's really fun for me as someone who is formally theologically trained with an MDiv, a lot of times people assume I did that before dental school. I actually did it after. Um, I cannot have this conversation without providing some sort of theological ethic and framing. I am far and away probably more humanities brained than science brained, if you will. I dare say if I look back at my transcripts from undergrad, all of my humanities coursework is glowing and my science, has some ebbs and flows in it. But for me, the work that I do day in and day out as a clinician, as an academician, as a someone who is a diversity practitioner, someone who is an ethicist, all boils down to this theological ethic and framing, and that is that of the Imago Dei, or the image of God. For those who may not be super familiar, it really speaks to the fact that each of us in humanity are what I like to refer to as image bearers of God, right? Even for those of us that may be non-religious, that may be agnostic, that might be atheist, not in a proselytizing sense at all, right? But grounding my work, grounding my viewpoint, grounding my vision and philosophy, whether that's a patient philosophy, a teaching philosophy, a research philosophy, is this notion that each and every human I encounter is an image bearer of God, right? And so because I see each and every person that I encounter as a really co-image bearer of God and this co-humanity that we share, then I have to respect the fullness of that individual. Does that make sense to everyone? So for me, that really paints the fact that all life is sacred and belongs to God, that humans have equal dignity, value, and worth, regardless of, but also inclusive of all of our various identity points, right? I think a lot of times we think about the identity points, particularly in a religious space, as maybe God or religion being no respecter of persons, or that there's a tolerance and that there's no division, right? But at the same time, I think we have to recognize that if we buy into this whole Imago Dei concept, right? This image bearer concept. Um, we can also maybe wrestle with God as intentional, if you will. And so for me, the body that I'm in, right, as a Southern Black male, heterosexual male is an intentionality, right? In the same way that I have to respect perhaps a transgender patient that is in my operatory, that is in my chair, there's an intentionality there. And I see that individual, pronouns or not, and all the other things that some folks like to debate. This is an image bearer of God. And so there's a certain level of respect and humanness and dignity and worth that I have to um, both respect and cultivate and continue to cultivate in that patient, in that person, in that colleague. Does that make sense to everybody? Um, Also knowing that humans do not earn this dignity, value, and worth. And that's where we really have a rub, I think, particularly in, sort of imperialistic, capitalistic, go empire, go government way of life, right? That I think if we're honest, we feel like some people are worthy of what have you, and others are not. Or some folks have earned what have you, and others have not. And I think that notion of hierarchy really gets us into trouble, right? Um, and I'll add to that, people should then seek the welfare of and care for others, including those who are different from them, right? So for me, as someone who is an ordained Christian clergy, I'm not looking at a patient, I'm not looking at a colleague in a sense to want to proselytize them. I actually want to learn those differences and be respectful and mindful of those differences and inclusive of those differences. So hopefully that makes sense for folks. I want to shift a little bit to some of our objectives around well-being and wellness. Depending on the day and depending on the moment, these terms are used interchangeably, which is somewhat complex or somewhat challenging, right? When is it well-being? When is it wellness? The World Health Organization defines health as inclusive of a well-being component, right? So a state of complete physical, social, and mental well-being, not merely the absence of disease. I think that's important for us to recognize, right? Goes on to say well-being is a positive state experienced by individuals and societies, a resource for daily life, on and on and on. For the purposes of this presentation today and the purposes of my work, I look at well-being as a bit more holistic and wellness as a component of well-being, right? So well-being being the broadest sense and wellness being sort of good health. So in that groundwork we're laying, we look at these 8 dimensions of well-being, right? And one of those is spiritual. So we have to recognize it doesn't mean that you have to be a pastor or a clergy or a priest or a shaman or any of those things, right? But recognizing the spiritual as a key component of those 8 dimensions of well-being is really foundational. When we look more at that spiritual dimension of well-being, it involves key principles, beliefs, and values that give meaning and purpose to life, right? So about living in a way that is consistent with a worldview, but perhaps also not, but also perhaps being tolerant of others who hold a different worldview. Spiritual well-being provides the capacity to love freely, to show compassion, which is important, certainly in healthcare delivery and oral healthcare delivery. I would connect even empathy into that, right? And we'll do some work around that later. An ability potentially to forgive, to experience joy, to seek fulfillment, and be altruistic, which is also connected to the roles of healthcare delivery, right? Practices that may demonstrate spiritual well-being could include knowing and living your values, beliefs, and convictions, being tolerant of the values and beliefs of others, discovering what gives your life meaning and direction, and viewing life as a learning experience and looking expectantly towards the future. It might be practical things like volunteering, setting life goals, working towards achieving those goals, but also making time for personal reflection each and every day. So these are some ways that the practice, that spiritual dimension of well-being shows up across the well-being spectrum, intersecting with healthcare delivery, right? Um, Some of the work I do is around professionalism norms. And what I mean by that is, particularly in the dental space, I think we tend to operate with a fairly narrow and antiquated understanding of professionalism that a lot of times, at least in the academy, boils down to how people look and what people wear, as opposed to behaviors and practices and principles, right? So one of the things that I've been doing scholarly wise in some of my work and some of the work I've seen in others is really looking at well-being as a missing piece of professionalism. I have this graphic from Stern, which helps us really see these different pieces that go into what professionalism is, right? And we see, certainly base level, that there's a clinical competence, right? That you have communication skills, that there's ethical and legal understanding. But then we start to get in these sort of abstract terms that are really humanities based, right? The bread and butter of humanities. When we think about humanism, when we think about empathy, when we think about altruism. So one of the challenges is that in the formal educational spaces for both dentistry, dental hygiene, or even spaces for dental assisting, maybe dental therapy, they're a bit absent of generally any type of humanities work, any type of humanities framing. It gets to be only very super technical. We're in a space where we do some work around communication styles, I think, but it's still very limited in how we introduce and connect some of these overarching humanities terms and fields with our clinical work. And there needs to be a bit more of a joining of arms there, if you will. One of my favorite graphics is from the National Academy of Sciences and the work that I've done around resilience and burnout and well-being, and the fact that, we are multifactorial. Our clinical spaces do not exist in a vacuum. And this graphic does a good job of centering the well-being of our patients, but the hinge point of that being the clinical patient relationship, and then that being predicated on what does the well-being look like for us as clinicians? What does the well-being look like for those of faculty who teach budding clinicians, right? And all of these factors that you see in that wheel go into that, and well-being is a real key part of what we understand as professionalism. I've done some work with some colleagues, Salim Razik from Canada and Preston Reynolds from UVA. I think this book is actually coming out in January, I believe, from Oxford University Press. But we have a chapter in there about a reimagined professionalism. And one of the things we push on in that work is the centrality of well-being and wellness as a hallmark of professionalism. And that really connects to spirituality and religion, because a large part of well-being for many folks is that spirituality and religion, right? Um, Not that I'm going to do a lot around health equity, but one of the things I think is really curious for me, that one of the things we argue in that book chapter is that reimagining professionalism should require or needs to include a complete dismantling of inequitable healthcare systems and structures, right? And so I know that's a lot, and that may be really wild to you. But if we look at the status quo and the fact that we have continually exacerbating disparities and inequities across healthcare, right? Don't we need to do something different to mitigate those disparities and inequities? I think particularly when we think about spirituality and religion and the ways in which spirituality and religion are sometimes wielded as weapons, or are a part of larger systems and systemic root causes of difference, hierarchy, and disparity. We have to include thinking about the ways in which religion and spirituality either contribute to those inequities or could be areas that help us mitigate them, right? Hood has some great work around health equity where she says expanding the definition of health equity to include the removal of obstacles to health and their consequences, including powerlessness, right? And so, particularly in the US, where Christianity is still seen as like I guess the powerful religious context, in what ways are we opening ourselves or exacerbating inequities for folks of other religions or no religion at all because they're not Christian, right? And in the ways that our systems are set up, in the ways that our patient interactions are set up, is really something that we should be mitigating, and that I think ethicists and folks who do humanities work can help assist us in doing that. Some of the other work I've done is around this notion of justice, right? And if you're not familiar, I know there are a lot of folks on here who may not actually be dentists, which is probably a good thing. Um, Dentists tend to be very narrow in our defining of justice. We tend to be quite narrow when we talk about ethics, even. Most dentists and most dental, even educators, when they talk about ethics, are going to be almost completely beholden to this little graphic on the side around the 5 principles of ethics that the American Dental Association advocates, holds up. I am an ADA member. However, I am quick to point out that the ADA is a member services organization, right? They are not, although they hold themselves out to be the voice of dentistry, they are really the voice of dentists. And they are the voice of dentists who are typically practice owners, and I dare say are more at times beholden to their capitalistic entrepreneurial identity than identity as healthcare provider, right? Or healthcare practitioner. I get in trouble for those kinds of statements, but I think it's okay, and I'm okay with that trouble because I think it needs to be problematized, right? And when dentists tend to talk about justice, they tend to simply talk about fairness. Um, if dentists are even talking about the social contract, right? This contract that we have to think of our patient before we think of ourselves, right? To our ethical responsibilities to do no harm. If we talk about those things, it's usually in a very small window or narrow window where we're simply talking about fairness, which allows us an ease of conscience to do great community service and go once a month and do some big tent event where we do free dentistry 1 day out of the year, but it absolves us of thinking about justice in a daily framework, right? And so some colleagues and I did some work where we really problematized the notion of the social contract altogether, because the social contract or social contract theory is not benign, meaning it's not without historic challenges of, say, oppression and sexism and white supremacy and all those sorts of things, right? And I connect this to spirituality and religion because spirituality and religion are often weaponized to be tools of oppression, or are on the receiving end of things like anti-Semitism, Islamophobia, and all those sorts of things, right? When we talk about hierarchy again and where that's a challenge. So I'm doing a lot of kind of setup theoretically, so hopefully you stay with me. We're going to do some practical things too, but this is the fun part for me. Um, so this notion that we should check our identity at the door. I don't know if you've ever been in a conversation or engaged with anyone where it's like, well, you should check your feelings, check your emotions at the door. There's some good work around inclusive teaching, and I'm going to extrapolate this out to patient care. But there's some good work around inclusive teaching and inclusive pedagogy by Ambrose that offers this, right? Even though some of us might wish to conceptualize our classrooms, for those of us that are in the academy, as culturally neutral, or might choose to ignore cultural dimensions, our students cannot check their socio-cultural identities at the proverbial door or the literal door, right? Nor can they instantly transcend their current level of development. But this notion of checking our sociocultural identities at the door, I would push this even further and say our patients should not be forced to check their sociocultural identities at the door simply because now they're at the dentist and we are parental in our notions to superimpose our westernized, Americanized values on this patient who may not have those same values, our religious spiritual values on a patient who may not have our same religious or spiritual values, right? So I think that's really foundational to understand. And I would argue not only should they not check it at the door, we should welcome it all and say, hey, how can we be more holistic and utilize and be inclusive of your spiritual and religious values to really get you the best care possible, right? Make sense? Great. Um, I'm not going to stay on this for the sake of time. I want to get to some other places, but my colleague Salim Razik, again, who's out of Canada, who's a pediatrician, but like a great social justice advocate, has coined this phrase and created this phrase around a professionalism of solidarity, which I just absolutely love, right? It embraces a commitment to act in partnership with communities to fulfill unmet needs, right? And so for a pediatrician, that may be you practice in the community where a good number of these young people do not know how to swim, right? And so to mitigate drowning deaths and swim injuries, there should be some onus on the profession to be involved with advocacy for ensuring that children learn how to swim. Does that make sense? All right. So in the same way, it emphasizes a need for understanding a patient's social context as a primary way to deliver care. It demands that we're committed to work for greater social justice, forces us to look at dentists and physicians as a group, forces us to look at the ownership of the profession's role in past injustices and a commitment to action for the future. Our spirituality and religion in this context is just as key, right? That we be in solidarity with our patients that may have a different religion or spirituality practice from our own to advance optimal healthcare for them, right? I hope that makes sense, and it's really foundational to my beliefs and where I'm going with this conversation. I cannot have a conversation around spirituality and religious beliefs and patient care without also talking about cultural humility. I know cultural competence is something that we often talk about, at least in dentistry. That is what is in our accreditation standards. But I really think cultural competence is the bare minimum. And I think cultural humility should be the goal, right? Because cultural humility for me incorporates within that a commitment to lifelong learning. I think sometimes this notion of cultural competence imagines we are at a place where I reach a zenith, right? I reach a point where I am competent and proficient in all I need to know about Islamic patients, right? Some weird thing, right? Like I know everything I need to know about interacting with patients who are Muslim, right? That's a falsehood, right? Things are always evolving and growing. And so cultural humility takes a stance that I'm always learning, I'm always evolving so that I can understand and provide better delivery of care to whatever patient group that is, right? And so with that example, Muslim patients. Culturally responsive care is a similar term that I think is just important for us to think about. And if you have time to read into it more, but it's really taking um, and incorporating the beliefs, values, and behaviors of patients' social and cultural backgrounds to make it relevant to their healthcare delivery. All right. So now a little bit more about the oral health connection. I think it's really interesting. There's limited research out there, right, about this connection, and it's has somewhat mixed results, if I'm honest. Um, the literature, there are few studies reporting on the association between religiosity and oral health. Some are positive and some are negative. So the frequency of attending religious services has been reported to be positively associated with preventative dental checkups, better self-rated oral health, as well as better oral health outcomes. There are some studies, one that looked at almost 1,200 Brazilian school children and demonstrated that a family religiosity measured by attendance at religious services and private religious practices was also positively associated with school children's oral health related quality of life. Okay. We have to also think about the ways in which religion and spirituality influence the ethical decision making of both patient and provider. So when we look at influencing factors like personal experience and upbringing, going back to the start of this conversation with how I talked about my own positionality, religious beliefs, professional training and experiences, practice locations, patient expectations, social customs, which can be heavily influenced by religion or spirituality, societal norms, which can be heavily influenced by spirituality and religion. All of these things go into making decisions for treatment planning, treatment recommendations, patient care, right? We cannot talk about delivering optimal patient care and leave religion as this aside extra thing, right? It is perhaps part and parcel of the full identity of our patients, right? There's also really interesting work out there around pain and religion, right? Pain and spirituality. Um, that kind of defines it or limits it to a coping mechanism, but I can give a practical anecdotal example, right? I still practice general dentistry, and often I may interact with patients who have chronic orofacial pain, right? And in many senses, some of the first line responses are to create, say, someone with bruxism or someone who grinds their teeth incessantly. Well, there's lots of information that says that that's likely stress associated or stress induced, right? So, in very chronic issues, we may send them to a specialist who is going to look at therapeutic options. That might be physical therapy, that might be pharmaceutical therapy, that might be massage techniques, that might be exercises, might be an appliance they create, all kinds of things. But we need to make room for the fact that perhaps a spiritual recommendation or spirituality for the patient, religiosity for the patient, is also a part of that armamentarium that we would throw at the problem, if you will, right? So this is a really interesting study. It's a small number, it's a small cohort, but I still think it's interesting, where they had 24 women with chronic facial musculoskeletal pain and 24 fully healthy women, if you will, where they had orofacial characteristics, diagnostic criteria. They also incorporated a spiritual perspective. They did some technical blood samples and all these kinds of things. But what did they find? They found that the study group that was much more spiritualized than the control group. So that's interesting, right? The folks who had this musculoskeletal facial pain off top were more spiritual, or at least by their assessment. But these individuals with a high score of spirituality had less myofascial pain, less bruxism, and fewer complaints. So it's really curious that spirituality and religion may move from simply a coping mechanism to actually be a treatment modality, if you will. Okay. There's also research out there around chronic pain sufferers and cancer patients, right? And the fact that religion and spirituality is a mechanism for them. This study also found that caries and plaque-induced periodontal illnesses that are sometimes linked to personal hygiene, food intake frequency, motivation to preserve oral health, and in certain circumstances, religious commitment. There's also this need to look at how we combat myths and misinformation and misperceptions around oral health practices and the way that religiosity may interact with that, and really or understanding any sort of connection to oral health literacy. Um, this also was a little bit more of a logistical regression model in this study, but where they looked at a higher level of religiosity as associated with superior dental health outcomes, mediated by high spirituality. So this study looked at a strong statistical association between caries experience and religiosity. The direction of the association suggested that being more religious was a protective effect for dealing with caries, right? So that's really curious and interesting. A conceptual hierarchical approach suggests a pathway to explain the association between the level of religiosity and dental caries experience. So in this study, the association was mediated by extrinsic, so social support, community support, and intrinsic spirituality pathways. Also, we have seen a good number of studies, particularly post-COVID and looking at the real height of COVID times around misinformation and disinformation, where a strong sense of community, belonging, and social capital have been associated with positive oral health outcomes. So what are you saying here, Carlos? I'm saying that communities and houses of worship can be key locus of information that patients otherwise may not receive, right? Health information, oral health information that patients may otherwise not receive, and a place that we can combat misinformation, right? And so I think that's important. So houses of worship or communities of worship are an essential source of community for many patients. I don't want to get, and this is too much text for one slide. I broke my own rule, but I thought it was interesting to look at some of the myths that houses of worship could combat, right? This is a study that looked particularly at women and oral health during pregnancy and early childhood. Some of the myths and information. I give my kids juicy juice instead of Kool-Aid because it has less sugar. If I give my kids Kool-Aid, I put extra water in it so it's less sweet because juicy juice is just so much better, right? When I was pregnant, my teeth hurt so bad during all my pregnancies. I actually went to the dentist at 8 months. It was terrible. After I had my son, I had two teeth pulled because of all the calcium that was gone. This is hard, limiting sweets, because my daughter will eat a whole honey bun by herself, but it's okay because she drinks water with it, right? Even things where they had some knowledge about fluoride being good, but there was still something about the knowledge that was misinformed. So fluoride tablets, if you will. When I was growing up, they would give me a chewable tablet that turned my mouth pink or red and showed how much decay you had. Is that what you mean? So no, that's not. That's actually a disclosing tablet to show you plaque in your mouth, not a fluoride tablet to help you have fluoride, right? So I think even water equity, I'm a part of some organizations here in Virginia that are really looking at water equity, which is fascinating to examine. I don't want to drink this dirty city water. We live in the projects or public housing. We probably have the worst water. I've always heard that our water is really bad for bacteria. It might have fluoride, but it has other stuff that is really bad, like chlorine and bacteria, and they tell you you should boil it. It even stinks to me. I can only drink it if I add sugar, and so then I just do the Kool-Aid, right? And so an understanding of all of this misinformation that patients may be having that could be um, course corrected if we engage with houses of worship to provide that information. Some other practical things as we're sort of wrapping up, because I want to get to a little bit of time for questions, is spirituality and religion in care delivery. So one of the things that we've done here at my institution is really particularly around Ramadan for our Muslim community, really ensuring that our students and our faculty have a better understanding of how any religion that has extensive fasting periods, how that may affect, um, the dental visit or compliance with the dental visit, if you will, right? So understanding how those religious holidays, understanding even around treatment recommendations and materials for, say, implants, right? So animal products. There are lots of religious groups that do not want an animal-derived product, such as Hindus or Sikhs, Sunni and Shiite Muslims, even Jehovah's Witnesses. You have to now there are variations within these groups. I can't speak for these groups as a whole, of course, and there are variations that may be okay with it, and sometimes there are extenuating circumstances where maybe they're not quite as devout, and so they're willing to take that recommendation if there's no other option. But some groups are going to be absolutely against any kind of animal derived product, right? We also have to think about how some of our customary Western gestures, like a handshake, that we view as polite, and other customs and cultures, religious or non-religious, where that is not viewed the same way. And so we have to be aware of that with our patient interactions. I'm going to kind of end, but I did want to just do where my mind is right now. in scholarly activity, I'm really interested in this notion of moral distress, right? And then for me, and how I look at moral distress is experiencing knowing the right thing to do, but being in a situation where it's nearly impossible to do it. So as a dentist, feeling like I know what is the right thing that might be founded in my spiritual and religious practices, but the system I'm a part of, for whatever reason, doesn't allow me to do it. So I don't have like an answer to that question or query, but it's something I'm really curious about, and how that shows up with spirituality and religion as a foreground or a background or underpinning, if you will, right? Um, I did want to just do this real quick because I'm a little bit of a nerd. I wanted to say, well, what does AI have to say about morality, spirituality, and religion? And again, I broke my rule here. This is way too much text that I wouldn't normally put on a slide, but we at VCU have a partnership with Copilot. And so I put in Copilot, what does morality, spirituality, and religion have to do with healthcare? And this is the answer it provided me, which is really kind of a summary of the talk I just gave, right? So morality, spirituality, and religion are interconnected but distinct concepts, all influencing healthcare in unique ways. Morality refers to principles around concerning the distinction between right and wrong or good and bad behavior, principles that guide individuals' actions and decisions. Examples might be decision making, where health professionals often rely on moral principles, ethical dilemmas. Spirituality is a broad concept that involves seeking meaning, purpose, and connection with something greater than oneself, which may or may not involve religious beliefs. That can look like patient well being, that can look like holistic care. Then, religion as a structured set of beliefs, practices, and systems, often centered around worship, health practices, healthcare decisions, and then the impact on healthcare, right? We just did cultural humility and cultural competence, the patient provider relationship, so effective communication, policy, right? Which, as we, have a new cadre of elected officials, you know, d- irrespective of your political positionality, if we are going to be duty bound by our ethical and professional responsibilities, there needs to be an engagement with policy of how spirituality and religion affects healthcare or is allowed to affect healthcare, right? Or we're allowed to talk about these things. Healthcare policies um, are often needed to navigate these complex interplays, if you will. So, in summary, morality provides a framework for ethical behavior, spirituality offers personal meaning and comfort, and religion offers structured guidelines that can deeply influence individual and collective healthcare choices. So I thought this was amazing, right? That it basically did my job for me and gave you guys a summary of what we talked about. I would be remiss if I did not. This is one of my favorite slides. I need to get with a graphic artist to update it, right? Because when we look at social determinants of health, I really think spirituality and religion belong there, right? Spirituality and religion can be such guideposts for many people and many populations, and it could be the fear of such, right? We talked about the rise of anti-Semitism, we talked about the rise of Islamophobia. All of that can go right here in the yellow with these root causes, along with all the other isms and phobias. And I think that's important for us to recognize and understand. I would be remiss if I also didn't share some work that a colleague and I did recently, really framing racism as combating racism as ethical and professional duty, right? And I think that connects with the spirituality and religion in the fact that we have these movements of anti-Semitism, we have these movements of Islamophobia, we have these movements of hierarchy and order and even anti-Palestinian types of movements. In that, how does this order and hierarchy and fear show up in healthcare? And I think we have to deal with that. And we need you all as humanities brained folks, as humanities scholars, as ethics scholars to help clinicians do that very, very hard work. That's it. I think we have just a couple of minutes for questions. I know I covered a lot of ground, and it might have been difficult content for some folks, but I love this statement around difficult roads leading to beautiful destinations. And this is just my family, my positionality as a girl dad through and through, and dad of three lovely girls, and my wife, who is really the MVP and a Loyola grad. So I've got to plug that in there. But what questions might we have that I can briefly tackle in the few minutes we have left?
So there is a question here. What does your idea of teaching oral care in the religious setting look like practically? In other words, what shape would it take in a church? Would you offer workshops, free dental care, something else?
Yes. So I think all of that, right? Um, I think it shows up in two places when I think about that question specifically. I think it shows up in community engagement, right? So the dental industry apparatus, if you will. So what I mean by that is from dental schools, dental hygiene schools, dental assisting schools, all the way to practitioners, um, dental service organizations, corporate bodies, private practices, all of those folks being involved in actually going out into the community and doing that work of sharing oral health care information and educating folks about the importance of oral health care to all those bodies. I think you could certainly partner with churches. You could certainly partner with synagogues. You could certainly partner with mosques. You could certainly partner with parishes or just community groups. Also, I didn't do a lot around like mindfulness and really spiritual practices like yoga and all those types of those are community groups as well that we could engage. So I think it looks like that on one end. On the other end, I think educating um, the future practitioners and current practitioners to understand why spirituality and religion are things that they need to understand and be a part of their toolkit, if you will. Not that they have to practice a certain religion or spirituality, but an understanding of how patients coming to us, how that enriches their experiences and how we can partner with their cultural norms and values to give them the best delivery of care. So to me, it's the education of the healthcare provider, but also going into the community and partnering with these religious spaces, communal spaces, mindfulness spaces, yoga meditation spaces to bring them the necessary oral healthcare information. So I think both and, if you will, as opposed to either or.
That answer really spoke to my public health brain. Thank you, Carlos. Everything about that was just a public health lesson for me. A couple more questions. Hopefully, we'll get to them all. Do you know of any research around spirituality and its impact on providers' mental health? The rate of suicidality tends to be high in this workforce, and I didn't know if there was research around this as a protective factor.
Yeah, I don't know of any specifically. Like I know that there is decent research around um wellness more generally speaking, well-being more generally speaking, like where we look at resilience, say, as a protective factor for burnout. Um, but I always get a little, even though I've done some work in that space, um, I'm always troubled or I feel a little bit problematic when we lift resilience sometimes as a solution, because it seems so individualized and individualistic as opposed to, say, if I'm burned out, like as a healthcare provider, some of that may be individual, but a large part of that is the system typically. So I can do chair yoga till the cows come home, but if I go into a toxic workspace day in and day out, my individualized intervention is still rubbing up against this systemic issue. And I think that's a real challenge. Again, I'll own this as a dentist, is that we are so accustomed to individualized interventions. Floss more, right? Brush your teeth. I'm not saying you shouldn't floss. I'm not saying you shouldn't brush your teeth, but we are so consumed with the individualized intervention. It's sometimes very difficult for us to get out of that brain to say, what is a systems approach to this need, right? So if the workforce generally has a challenge or a problem, or even in public health spaces, I'll hear solutions that say, which are worthwhile to talk about, right? Say you have a dental clinical enterprise, and we want to mitigate social determinants of health around access to care. So we want different hours. We want evening hours. We're going to set up evening appointments so that patients who work hourly jobs and don't have access to take leave, or it's frowned upon, or they're threatened to be fired if they take off to come to a dental appointment, right? Because that's some folks' reality. We're going to have these evening hours. Where are we also thinking about our workforce? And the fact that we can't just make the workforce work a longer day. Like, are we going to have flexible hours where the hours now go from 12 to 7 as opposed to making someone stay extra hours, right? So we have to think about the both and in that way too, in terms of well-being. But I do think it's definitely worth investigating to see what are protective mechanisms for burnout, what are protective mechanisms for issues around wellness and well-being. For me, certainly being grounded, just my own anecdotal experience as someone who's a Christian, as someone who prays, those are without question practices and factors to help me keep balanced, right? To help me engage the difficult work that we face day in and day out. So I think there's much room to do that work for sure.
Okay, thank you. There's another question here specific to something you've been doing at VCU. Do you think it's a good idea to have a presentation about oral health and diet before Ramadan in the city Islamic centers? Any suggestions? Did anyone do something like this before, and can those materials be shared?
We have not done that specifically. Our education was really to help our students and faculty and staff understand we have a pretty sizable Middle Eastern patient population, and to understand why they may not want to schedule an appointment during that time where they could inadvertently swallow water, right? Or something of that sort. Or if there is a concern around a malodor, like embarrassment, because they're not eating and they're not maybe brushing in this specific time frame or something like that. We have not yet partnered with any community groups around that specifically, but I think that's a wonderful suggestion. Um, but I think, I would just give this caveat. When you do community engagement work, be sure that you're engaging, they are experts on themselves, right? And so we
Mhm.
have to be very mindful that we don't go in with this sort of ivory tower. I am the professional. I am the healthcare expert. Let me come talk to you about such. I think what actually works, and there's lots of scholarship around community engaged scholarship and community participatory research, where you have to engage them and say, hey, what are your needs? Like, how can we best serve you? Instead of me coming, like, we're partnering right now, we're in conversations to partner with a local middle school that's literally almost across the street from us, right? And initially it was like, oh, we can make mouth guards for them. We can do this, we can do that. And I said, well, wait, like, let's engage them and say, hey, if we came and became a real partner and a good neighbor to you, what are some of the things we could help you do? Right. And that sparked a completely different conversation than, hey, what are just your actual dental needs? Because needs are holistic, right? Does that make sense? So I would encourage that type of work, but I would just be mindful that you do it in a way that is giving full respect to your community partners. And if there's any work you're doing, I would also advocate for like a community advisory board, like if you're either a nonprofit or a clinic or something like that, to where they have real actual input into processes and practices of what's happening in the community, because they are the experts on themselves and the experts on that community.
Thank you for that. Thank you for this discussion. I apologize for those questions we were not able to get to, but we are just at time. And I really want to thank you, Carlos, for an incredibly engaging, important discussion. So many things to think about and something we don't discuss often enough. So thank you for your time and your insight. This was really amazing. So as I mentioned, anyone who RSVP'd, the link will be circulated with the recording to the session, and this will also be posted on the CU website. So thanks everyone for joining us. We look forward to seeing you next time around. Thanks. Bye-bye. That was great.